I think one of the most important features is that it's really like an instrument. And so it's done in the exact normal surgical sequence that we do. So we make our clear corneal incision, we put in viscoelastic, and then instead of putting in a cystotome or a forceps, you put in the Zepto through the clear corneal incision, you retract the rod, it opens up. The steps are mainly to center it on the visual axis. The central area is actually clear. There's a little window. So there's actually a way for the patient to fixate through that clear opening on the Purkinje images, of on the microscope light. And you are then, the surgeon is centering it on the Purkinje images. And then basically there's a little console. It's very small, and a circulating nurse could operate this. And you basically first apply the suction. You see the little bubbles move with the suction. Then the surgeon says energy, and that creates the cut. And then the final step is a release of the suction, and then you simply pull the device out, and it unfolds on its own because, again, of the nitinol ring being very collapsible. Well, of course, all IOLs require a centered round capsulorhexis or capsulotomy, so really it's used for all of the IOLs that I use, both monofocal and then all the premium lenses, whether it be multifocal or extended depth of focus, toric, and so forth. Well, I think the beauty of Zepto is just the flexibility to use it in a number of different situations. But it's really fantastic, for example, for the white cataract, for the small pupil. So I don't think it's mutually exclusive with having a femtosecond laser, because again, with complicated cases, there's really, if the patient's not having a refractive IOL and just needs a monofocal IOL, there's really no reimbursement with the femto in that situation either. So the fact that it is so versatile, you don't have to use it on, you may just use it on a very small select number of patients. I think it's just wonderful to have in your surgical armamentarium. The learning curve is actually quite easy because you have to basically learn how to extend the rod, which elongates the tip so that it passes through a small incision. And then the sequence is really a matter of calling out the steps that you want. Suction, cutting, and then release of the suction. So that's one of the beauties of it. And I would say certainly after a couple cases, one is going to be pretty proficient at that. So I think that's really one of the great things about it, is that the learning curve is so short. Yes, well, I think that, of course, is one of the important things that Zepto brings to the table, and it's a totally different cost structure. The unit itself is on the order of 10,000 US dollars. And then depending on the volume, one would expect to pay somewhere, let's say a starting point of about 150 US dollars per instrument for single use, but there's really no other costs involved. And I think those, again, are things that can change depending on the volume that one has. And so I think that's one benefit. There's next to no real investment on the part of the surgery center. And so people don't have to commit to using it on a certain number of cases for the next 5 years. They can try it out in different situations and make an individual decision on when they want to use it. But whenever we do complicated cases, we incur certain costs with devices, whether they be a pupil expansion ring, a capsule tension ring, trypan blue dye. But overall, it probably is cost effective when it prevents complications from occurring in those complicated cases. And then with premium IOLs, I think the way that many people have justified the cost of femto is that the patient is already making a significant investment in their outcome, and we want to be able to give them all of the best services and the best technologies we can as part of that premium IOL outcome. And so Zepto again would fit into that model as well. The beauty, though, is it gives the surgeon the flexibility to really decide when to use it without having to make some type of commitment on volume to justify the large expenditure. There's no large upfront expenditure, and certainly you don't have the maintenance costs on an annualized basis. One of the interesting things about Zepto is, again, being able to center it while the patient is actually fixating on the operating microscope light. And so at least it creates that theoretic possibility that you can actually put the capsulorhexis and center it on fixation while the patient's actively fixating. So there's really no other good way to do that at present time. And although you can center the lens in the pseudophakic state on the operating table, it's already too late if you've created the capsulotomy. So the idea here is if you can center the capsulotomy on the visual axis, then it's going to be quite easy to have the lens center and line up with that.